Good day everyone. Today we will be discussing about potassium chloride. Potassium chloride comes under the class of electrolyte supplements. Regardless of the administration route, potassium chloride is used to increase the potassium content of the body. Approximately 98% of all potassium in the body exists within cells, particularly skeletal muscle cells. This intracellular predominance is utilized by all cells for tonicity homeostasis and membrane potential dynamics. In cardiomyocytes and neurons, repolarization occurs through the movement of potassium ions out of cells through channel proteins. Both hypokalemia and hyperkalemia can interfere with normal cardiac electrophysiology, potentially leading to life-threatening arrhythmias. Notably, potassium abnormalities rarely manifest as central nervous system pathologies like seizures. Potassium chloride is the preferred agent for correcting most presentations of hypokalemia. DKA usually presents with hyperkalemia due to the associated hyperosmolality and underlying insulin deficiency. When administering insulin to move excess glucose from the bloodstream into the intracellular compartment, potassium moves intracellularly as well. As hypokalemia can result from insulin treatment, the clinician can administer potassium chloride to maintain an adequate serum potassium level. Renal potassium handling plays a significant role in determining the serum potassium level. Most potassium reabsorption occurs at the proximal convoluted tubule and loop of Henle. Potassium secretion begins at the distal convoluted tubule. The collecting duct may secrete or reabsorb potassium based on input from chemical messengers like aldosterone, tubular delivery of water and sodium, and serum potassium status. Pathology at any of these segments can influence how much potassium is retained or excreted. Examples of tubular pathologies that result in hypokalemia include genetic channelopathies, such as Bartter syndrome, and type 1 renal tubular acidosis. Hyperaldosteronism. Aldosterone is a mineralocorticoid that signals renal collecting duct cells to both retain sodium and water and secrete potassium and hydrogen ions. Conditions that promote excessive aldosterone activity can lead to excessive potassium secretion, leading to hypokalemia. Hyperaldosteronism can result from conditions that either produce excessive aldosterone, like aldosterone-producing adrenal adenoma, or aberrantly stimulate the renin-angiotensin-aldosterone system, such as renal artery stenosis. Excessive mineralocorticoid activity can also occur in aldosterone-independent manners as well. Medication-induced hypokalemia occurs primarily via renal potassium loss or intracellular shift. Diuretics, excluding potassium-sparing diuretics, corticosteroids, and certain antimicrobials promote urinary potassium excretion. Examples of medications that promote the intracellular movement of potassium include 2-receptor agonists and xanthines. GI-related potassium losses primarily occur due to vomiting and diarrhea. In vomiting, there is renal wasting of potassium induced primarily by metabolic alkalosis. Metabolic alkalosis results due to the loss of hydrogen and chloride ions. To replace the lost gastric acid, reactions involving carbonic anhydrase occur within parietal cells to yield hydrogen and hydroxyl ions. The hydrogen ions are secreted into the gastric lumen, while the hydroxyl ions react with carbon dioxide to form bicarbonate. Bicarbonate then enters the bloodstream, resulting in hypochloremic metabolic alkalosis. In diarrhea, potassium is excreted with sodium, bicarbonate, and water, resulting in a hypochloremic metabolic acidosis. In the setting of diarrhea, potassium bicarbonate is preferable to potassium chloride. During cardiac surgery, potassium chloride serves to induce cardioplegia by interfering with phase 0 of the cardiac action potential. Cardioplegia allows surgeons to operate directly on the heart, while maintaining tissue perfusion with extracorporeal life support. Adverse effects from normal use of potassium chloride are typically related to the administration route. The FDA notes particular adverse effects for each administration route. In general, oral formulations most commonly correlate with GI irritation, including vomiting and diarrhea. Tablet and capsule forms may cause ulcerative or stenotic lesions with prolonged exposure to GI surfaces. Injectable KCl formulations have the potential to cause injection site complications like phlebitis, erythema, thrombosis. Also, rapid injection of potassium chloride can precipitate mild hyperkalemia.
As potassium chloride is used to increase body potassium content, its use with other drugs that achieve this outcome is contraindicated. Examples of such medications include potassium-sparing diuretics, nonsteroidal anti-inflammatory drugs, and angiotensin-converting enzyme inhibitors. Certain medical conditions involve hyperkalemia as part of their pathophysiologies. As such, potassium chloride use in these cases is contraindicated. Examples of notable conditions that involve hyperkalemia include type 4 renal tubular acidosis, chronic kidney disease, and leakage from cell breakdown, such as rhabdomyolysis, tumor lysis syndrome, etc.
Given the narrow normal range of serum potassium, careful monitoring is a requirement when utilizing potassium chloride. For hospitalized patients receiving oral potassium chloride, serum potassium checks should occur at least daily to determine treatment effectiveness. Patients treated with intravenous potassium chloride require more frequent checking, especially if the serum potassium level addressed is below 2.5 milliequivalent per milliliters. The use of continuous cardiac monitoring can aid in correlating symptoms with telling ECG changes like peaked T waves in hyperkalemia, flattened T waves in hypokalemia, etc. Thank you. Kindly comment for further queries and doubts.